Hi, we are starting another of our Pandemic Insight series, and I'm really happy to be talking today with Natalie Fixmer Oraiz, who is currently an assistant, but very soon to be an associate professor in communication studies, and she is also in gender, women's, and sexuality studies, and also is going to be an Obermann Interdisciplinary Research Grant Fellow this summer. We hope in person, but potentially virtually. So welcome. Natalie is somebody who works on reproductive rights and the language around reproduction. I've been thinking about you and wondering how this moment of COVID-19 is resonating with your work and your thinking.
Yeah. Thanks for having me, first of all.
Mhm.
And my book that came out last year talks about how I'm a communication scholar and I'm interested in how the words we speak reflect common assumptions and beliefs and how we can use words to build better worlds. And in this moment, what has really struck me is that we're using the language of emergency. We're using the pandemic. Governors across the country, including Kim Reynolds, have used this pandemic to suspend reproductive rights. And we're seeing the confirmation of that approach by the Fifth Circuit Court of Appeals just this week, which affirmed Governor Greg Abbott's right to suspend constitutional rights to abortion in the midst of a pandemic. And so my first book looked at how discursive alignments between motherhood and nation. So I looked at how in the Homeland Security states, I looked at how the logic of Homeland Security culture and its accompanying rhetorics like emergency and crisis and security, are used to police and surveil pregnant people and mothers in ways that align with the interests of the nation.
And you were talking about some examples in the wake of 9/11 of what that looked like.
Yeah, so um, my book spans about 15 years post 9/11, and different case studies take up different moments in that history. So I have an early case study that looked at, in the immediate aftermath of 9/11, how there were a lot of pronatalist campaigns that targeted especially wealthy white women to serve the nation by going home, right? And that expressed um, the height of feminism was being expressed in this moment by opting out. Some people may recall this opt-out revolution that got a lot of coverage in mass media, where women who had achieved like really elite careers were trading in those careers for full-time domesticity and motherhood. So that's one example that I talk about a little bit in my book. I also trace the rhetoric of fetal risk and how we saw a kind of uptick in the prioritization of the fetus over the health of the pregnant person, the mother. And that has in very intense ramifications. Just here in Iowa 10 years ago, we saw the incarceration of a pregnant woman who fell down a flight of stairs while she was pregnant and went to the ER, and was, because she expressed ambivalence about her pregnancy, she was arrested and she was accused of the exact terminology was attempted feticide. Now, the state dropped its charges a couple days later, but other women have not been so fortunate, right? The state, in Indiana, we see the prosecution of Puri Patel and Bebe Shui. So there have been the criminalization of pregnancy, and that criminalization has really had a disproportionate impact on poor women and women of color and immigrant women in this country.
And so currently, what some of these governors, including Kim Reynolds, what is that has been their argument for trying to limit access to abortion at this particular moment?
They've argued that they are suspending all non-essential medical procedures in order to preserve personal protective equipment and to safeguard healthcare workers, essential healthcare workers, from interacting with anyone who doesn't absolutely need their services, right? To kind of flatten the curve of transmission of this virus. Uh, so Kim Reynolds issued this proclamation at the end of March. And within a week, there was a lawsuit filed, and the state and the ACLU, the primary plaintiff in the case, they reached an agreement, which was that the proclamation would remain in place, but that it only covered non-essential abortion care. So basically, medical providers, abortion care providers in Iowa, have been given the freedom to determine whether or not an abortion, a surgical abortion, is essential care. The reason that, well, I don't know, maybe I should stop there.
Well, what kind of response has there been from the medical community and potentially from clinics in terms of this argument that this is taking away from those frontline workers and any of the equipment or something?
Yeah, this is how the logic of emergency works, right? It kind of, it heightens people's sense of fear and anxiety because, of course, in a moment of pandemic, all of us are committed to preserving the health of our healthcare workers. All of us are committed to trying to make sure that we are preserving personal protective equipment, right? Those are national, global priorities right now. But if you look at the evidence, right, reproductive healthcare advocates and healthcare providers have been really clear that abortion bans do absolutely nothing to preserve personal protective equipment, and in fact, may use more personal protective equipment in the long run. Think about it this way. So an abortion in the first trimester uses two sets of sterile gloves and a reusable face shield. It doesn't typically require any gowns or masks. But think about prenatal care and childbirth. And given that 33% roughly of births in the United States are by cesarean, think about all of the personal protective equipment that has to be used over the course of a pregnancy, 40 weeks, and then through childbirth, depending on the circumstances. So abortion actually uses far less personal protective equipment than pregnancy and childbirth. And, in fact, if we think about how can we hold these goals together, right? Mm-hmm. How can we both, on the one hand, say we want to support abortion as essential healthcare? It's time-sensitive healthcare, and as you delay abortion care, it doesn't diminish someone's desire or insistence on acquiring abortion. It simply puts hurdles in the way, right? And we know that when people are up against a wall, they will do anything in their power to terminate a pregnancy if that's what they feel like they need to do for themselves and for their family. And so we're seeing people traveling across state lines from Texas to Denver, right? Exposing themselves to the risks of contracting a coronavirus as they travel. Sometimes they travel with their children, they're staying in hotels. All of this to simply acquire a constitutionally recognized medical right to care. Right. So I lost my train of thought, but we can affirm on the one hand that this is essential medical care, and we can preserve personal protective equipment and the healthcare or the health of our essential workers by expanding access to telehealth. Because in the first trimester, there have been numerous studies that have confirmed that telehealth access to medication abortion, the abortion pill, is a great way of expanding access, eliminating the necessity of personal protective equipment, and creating distance between healthcare providers and patients. And in fact, Iowa had the very first telehealth abortion care. We were the first state to offer telemedicine abortion care through Planned Parenthood of the Heartland. And so the way it works is that you visit a healthcare center for consultation and screening, and you're connected to a clinician in another location through video conferencing, and then you get remote authorization for medication abortion. And so you can administer that at home.
I remember, go ahead.
No, go ahead.
I was listening to an NPR program last year, an interview with a woman who is traveling by boat around the world, providing the pill in the early stages of pregnancy to women in countries who do not have it available. And somebody just would kind of row out to the boat, get a basic checkup, get the pill, and and then somebody would ferry her back to shore. So it's kind of like where there's a will, there's a way.
Yeah, and I think that when we think about these restrictions, they don't do anything to flatten the curve. They don't do anything to preserve protective equipment. They just hurt people. They hurt people who are desperate to get the health care that they need. And they hurt people in a time when 10 million people and counting in the United States have filed for unemployment. People are financially devastated by this, whether you're talking about the loss of job and income security or the loss of a retirement fund. I mean, people are hurting across the board, and there's a lot of uncertainty and fear. People are trying to do the very best they can to parent through these conditions. And the last thing you need is the state forcing you to travel across borders in order to attain a healthcare service that you desperately need.
Yeah. And we talked a little, and you've already touched on this slightly, but the work, for example, of Naomi Klein and shock therapy, and the way that things become normalized at times like this.
Yeah, that Naomi Klein's book, the Shock Doctrine, was so helpful to me when I was beginning to write my dissertation, because she talks about political shock therapy and how, she traces this from like the mid 20th century forward across a variety of contexts, both in the US and in Latin America primarily, but just talks about like the exploitation of disaster and whether those disasters are real or imagined, right? But the exploitation of disaster in order to implement deeply unpopular, oppressive policies when citizens are just exhausted and distracted, and they can't resist and they can't organize in the ways that they would normally. And so this is kind of quintessential shock doctrine, shock therapy, political opportunism, right? To say, in this moment of pandemic, we're going to use the pandemic and we're just going to ban abortion care, right? It does nothing in terms of the public health good, in terms of the pandemic, but it certainly does advance a political agenda that's been around on the right for a long time.
Yeah, and we were talking just a little bit about both of us trying to remember some reproductive related cases that we think are coming before the Supreme Court, and it's like in all the news saturation, it's like you can't even keep track or remember. So it is that like distracting.
There were a number of bills in Iowa this session. And of course, states across the nation are taking aim at this. They're aiming for a Supreme Court overturning of Roe versus Wade, because they really feel that with Kavanaugh now on the courts, they have an opportunity to overturn constitutionally recognized abortion in the United States. And so in Iowa, we had numerous bills, including an attempt to amend the state constitution.
And you also mentioned that there was Hyde Amendment language in the coronavirus relief package.
Yeah, there was an insistence by GOP leadership to include Hyde Amendment language in the coronavirus relief bill to ensure that no federal dollars were spent on abortion care. And the Hyde Amendment has been around since the late 70s. It was the first major blow to reproductive rights access, and it targeted poor women, right, in the late 1970s. making sure that women on Medicaid couldn't use their healthcare coverage to pay for abortion services.
So just to pivot a little, I'd love to hear about the project that you'll be working on via the Interdisciplinary Research Grant, and that you're doing in collaboration with a visiting scholar. You can just give
Yeah.
a little overview of that.
Yeah, so Sharon Yam is my collaborator at the University of Kentucky. And she and I are working on a project about how healthcare advocates, reproductive justice activists, healthcare providers, doulas, midwives, and then kind of national advocacy organizations are navigating questions around gender in the context of pregnancy and childbirth. So there have been a lot of conversations around how do we create gender affirming reproductive health care. Historically, there's just a lot of talk about mothers and women, pregnant women. How do we include trans and non-binary birthing people and parents in that discourse, right? How do we build healthcare services, reproductive healthcare services that are attentive to the various forms of gender, how gender is diversely expressed and embodied and experienced in the context of reproductive healthcare? And at the same time, how do we use language in ways that can also signal the very deep, long-standing histories of misogyny that are specific to the way that reproductive rights get curtailed and abused, violated. Mm-hmm. So we're doing a number of interviews with various stakeholders to look at how are they thinking about language in this moment, and how are they thinking about language that can be both inclusive of a range of gender identities and experiences and specific to the ways that misogyny are bound up in reproductive politics.
Well, I look forward to having you at Obermann. I hope it's in person.
Me too.
So thank you so much for this time and for just sharing your insights into language and just your in-depth knowledge around this really important topic.
Thank you so much for the invitation. This has been a pleasure.